Okay, welcome everybody. I'm Sharice Magoon and I work in the Department of Lifelong Learning here at UT Health San Antonio School of Nursing. I'll be moderating the session today. This morning you were sent an email from Cynthia Gutierrez, and at the bottom of the email it explained how to complete the evaluation and how to get your CE certificate. So if you have any questions regarding that, if you will get with her after the presentation's over, she's going to type her email address in the comments so you can reach out to her. This symposium is sponsored by Texas Health and Human Services Commission in partnership with UT Health San Antonio School of Nursing. Texas recognizes June as Neonatal Abstinence Syndrome Awareness Month. You can learn more by reading House Bill 405. Please keep your camera and microphones off during the presentation. And if you hold your questions until the end, if you want to type them in the chat while you think about it, and then at the end I can read them. But at the end, if you want to type your questions in or unmute yourself, you're more than welcome to ask questions, give your thoughts and comments. I'd like to introduce our three presenters today. Liz Conville is the project director for Texas Maternal Opioid Misuse, which is MOM, model at Texas Health and Human Services Commission. She has spearheaded multiple maternal behavior health projects within Medicaid Office of Policy team. She previously worked as a substance abuse prevention specialist and peer support specialist in direct service roles. Liz has a bachelor's degree from Illinois State University and a master's degree from Clinton School of Public Service in Arkansas. Our next presenter is Ybarra, and she is the nursing manager for maternal substance use and outreach at Harris Health System. She works at Ben Taub Hospital, where she manages the perinatal substance use program, including the maternal opioid misuse model grant, which was awarded by the Centers for Medicare and Medicaid Services Center for Innovation. Emily's career has centered around work with vulnerable populations, advocating for low barrier access to compassionate and high quality care. Her nursing degrees are from UT Health Houston's CISIC School of Nursing and include a master's in nursing leadership and her BSN. She is also a social worker and alumnus of UT Austin. Our third presenter is Dr. Jenny McKinney, who has an MD and MPH. She completed her OB-GYN training at University of Colorado in Denver, and then her fellowship in maternal fetal medicine at Baylor College of Medicine with a focus on infectious disease and substance use in pregnancy. She is currently an assistant professor of maternal fetal medicine at Baylor College of Medicine and Harris Health System in Houston, Texas. Her primary clinical and research focus has been to identify barriers to optimal care during pregnancy and work on designing and implementing programs to remove the barriers and improve health outcomes for pregnant women who experience vulnerability. She currently is a co-lead of clinics caring for pregnant women living with HIV and substance use disorders in our county hospital system, and has been involved with efforts to improve care for these populations and the local and state levels. Without further ado, I will hand it over to you, ladies.
Hi, good morning. Thank you so much, Sharice, and I wanted to thank UT Health as well for having us today. As mentioned, my name is Liz Conville, and I work at Texas Health and Human Services Commission in the Medicaid program policy area. I'm very excited today to be co-presenting with Dr. Jenny McKinney and Emily Ybarra, who I've had the privilege to work with on the MOM model. And I also wanted to add that I've attended this symposium for many years, and I've always received a lot of really valuable takeaways. So I'm just honored in that regard as well to be speaking to you all today. Next slide. I want to just look at the quick agenda for our presentation. We are going to be covering a lot of different topics, sort of a potpourri, and we all bring really unique perspectives. So I'm just so excited to be sharing this information with you today. Dr. McKinney is going to start us off discussing the broader context of substance use disorders in pregnancy. The middle portion, I'm going to be discussing some Texas Medicaid offerings for pregnant women with substance use, looking at some benefits, overview of some managed care programs, and talking very briefly about the Healthy Texas Women Plus program. And then Emily Ybarra will finish off the presentation talking about the amazing work that's being done at the Houston-based integrated treatment clinic where the MOM model operates. And so I'm going to hand it over now to Dr. Jenny McKinney.
Thanks, Liz. Okay, so as Liz mentioned, I'm just going to briefly kind of set the stage for the issue of substance use disorders in pregnancy. Some of this information you've probably heard before, but I hope to kind of make a case for why this is such a big deal to us, why it's so important to us. And then briefly at the end, mention a little bit of medications for opioid use disorder. That could be a multi-hour talk on its own, but I'm just going to highlight a few things, common misconceptions that we have heard in our work with both patients and providers in the community. Disclosures are that I do receive funding from CMS for the maternal opioid misuse model that's going to be discussed later today. I also receive funding from DSHS for implementation of the AIM bundle for substance use disorders in Texas. So I just wanted to start with really basic numbers. So, when we think about substance use disorders, I think, maybe 10 years ago, people just weren't really aware about how big of a deal this was. These are the most recent numbers. NSDUH is the National Survey on Drug Use and Health, and this was the most recent data from 2018. There is some new data from 2019 that is coming out, so should update these. But you can see that in general, people who are pregnant tend to use less than those who are not. But still among pregnant people, about 5% report using illicit substances. When you add on any alcohol use, that goes up to 13%, and then over 20% when you add on tobacco use. Some people might say, oh, 5%, is that really that big of a number? But when you think about all of the effort and resources that we put into something like diabetes management in pregnancy or chronic hypertension in pregnancy, where those the prevalence is 1 to 2% for both of those. This is a huge deal. So it is good that people who are pregnant, the pregnancy tends to be a motivator, and some people do not continue to use. We know that if people start the pregnancy using substances, use does tend to decrease over the trimester. So what you're seeing on the bottom graph there is the blue shows the incidence of people who are not pregnant, and then red is first trimester, green is second trimester, and purple is third trimester. So you can see that trend and decrease over time. So the left graph is just another illustration of that abstinence or stopping use of substance during pregnancy does increase over the weeks of gestation, over the weeks of pregnancy. Unfortunately, the graph on the right side showed the significant risk of relapse postpartum. One recent survey showed approximately 80% of people end up relapsing, with the highest risk of that being immediately after delivery. The trends in pregnancy, especially for opioid use disorders, mimics the trends in general population. So on the left there, you see the slide we've all seen a million times of just the huge number of increase in opioid use disorders over time. On the right side shows the data in pregnancy. So we see that the proportion of pregnant women as a total percent of female admissions, that blue dotted line, has remained steady over the years, but that red dotted line is showing a huge increase in the amount of people, pregnant people, that report any use of opioids. And then the solid gray line is the proportion that describe opioid as their primary substance of use. This is a little bit of the data from the most recent drug use survey in 2019 that just kind of splits it out. So you can see a little bit over the last 4 years for illicit drugs, tobacco products in the middle, and then alcohol at the end. And so you might say, oh, maybe the percentages of illicit drug use is about stable over the last couple years. When you split it out, that you see that there has been a significant increase in marijuana use over the last 2 years. Again, some people are like, marijuana is legal some places, not legal in others. Is it really a big deal? And that is one of the biggest things that came out of this survey, is that when you compare a group, so sorry about all the little numbers, but I'm just going to describe what this is telling you. So basically, when you compare a group of pregnant women with no use of marijuana in the last year to a group of pregnant women that have used marijuana in the last year, you see a huge increased risk in terms of use of other substances such as cocaine, pain reliever stimulants. You also see significant increase in mental health issues. So whether that's incidents of severe mental illness or major depressive episodes. So this is just one reason, we really need to be watching these numbers. We may think that there have been some improvements, maybe a little bit less of opioid use in pregnancy over the last 2 years, but we're seeing an increase in marijuana, and that has significant serious effects. Thinking about in general, the association of substance use disorders, and this is any substance use disorder and pregnancy outcomes, we know that untreated substance use disorders have been shown to be associated with lack of prenatal care, increased problems with baby's growth, increased placental problems, including abruption, increased intrauterine fetal demise, increased preterm labor, increase in utero-meconium passage, which is when babies have a bowel movement inside from increased stress, and increased high-risk activities, for example, transactional sex or criminal activities, which all of themselves have an increased risk of STIs, violence, and legal consequences for the mom and her family. We also most significantly see an increased risk of severe maternal morbidity and pregnancy-related deaths. And I just want to take a couple of minutes to show you some of the data supporting those really severe outcomes. First of all, severe maternal morbidity, if you haven't heard of it before, it's a list of very serious diagnoses that are basically the graph on, excuse me, the graph on the right side there lists them, but these are things like acute renal failure, sepsis, eclampsia, really severe outcomes with pregnancy. And we've had multiple studies. I just have a couple demonstrated here. One, so anybody with any pregnant person with a history of opioid use disorder or stimulant use disorder have an increased risk of severe maternal morbidity. And this was specifically in one study, they showed that opioid use disorder had an increased risk of SMM by 50%, and stimulant disorders almost a twofold increased risk of SMM. If you look at it on the other side, for all women with an incidence of severe maternal morbidity during their pregnancy or after their pregnancy, they had a nearly twice as high risk of being coded for either having a substance or alcohol use disorder or dependence in the year following delivery. So a really close connection between severe maternal morbidity and substance use disorders. Taking it one step more severe and looking at Texas pregnancy-related deaths, we know that pregnancy-related deaths are any deaths that are directly from either pregnancy complications or from a chain of events that was initiated by pregnancy, or aggravation of another unrelated condition that was aggravated due to the physiology of pregnancy. When we look at specific data for Texas, the most recent one we have is looking at cause of death in Texas from 2012 to 2015. And we see that 17% of overall pregnancy-related deaths were due to substance use disorders, either directly due to drug overdose or other substance use sequelae. Of those, 60% involved opioids and 66% involved polysubstance use. And we see that trend in our clinic where the vast majority of patients have used multiple substances or are using multiple substances. When you look in more detail at those deaths, all of the deaths that were related to mental health conditions, including substance use disorder, are coded as either some chance or a good chance of being preventable. So there is something we can do about them. I just want to take a quick look at data from another state, from Massachusetts, just because I think it illustrates a couple of good points. There is data like this from a whole variety of states across the United States. This just shows the longitudinal prevalence of pregnancy-related deaths related to substance use disorder by year, and you can see that increased number over time when you look at the data from 2005 to 2014. We see that in terms of the timing of substance use related deaths, most are happening in that 42 days to first year postpartum. And that's really important because, historically, pregnancy coverage for medical care has usually expired around 6 weeks after delivery. And we're seeing this trend with substance use and also with a variety of other reasons for pregnancy associated deaths. But just a reminder to all of us that this isn't right after pregnancy, that these patients can have poor outcomes and related deaths within the first year postpartum. This just shows that when you look at all the pregnancy-related deaths associated with substance use disorder in Massachusetts, opioids are the highest, the most prevalent substance involved in those, up to 66%. When you look at the opioids that have been involved, heroin and fentanyl are some of the most common. And we're again seeing that at the ground level in our program in Houston. This slide I could take an hour to just go over this slide, asking the question, why is severe morbidity and mortality higher for pregnant people with substance use disorders? I'd like to just briefly say that, it's for a lot of reasons. There's a lack of policies and practices. Few healthcare systems have implemented universal screening. If you don't know there's a problem, it's hard to address it. Referral sources are rare and sometimes hard to get to. And there's just a lack of training and education in general. Lack of coordination between providers and gaps in treatment is also a big deal. This is one of the biggest, I would say, public health issues that really highlights the need to integrate hospital clinic care with community resources and care. And I think this is, compared to dealing with like hypertensive disorders in the hospital or eclampsia, postpartum hemorrhage, those are very much, you can kind of focus your efforts on the hospital side. Substance use disorders, we do not have that luxury. We have to be integrated with the community system, which of course is more complex and lends an additional barrier to making sure people get the treatment they need. Social drivers of health are also a huge deal in this population. Thinking about someone who's on methadone and needing to get to a methadone clinic every day, transportation can be a huge barrier if that transportation doesn't allow children. Childcare is an issue. Housing, food insecurity, all of these things that are affecting all of our pregnant patients are especially an issue for the population that's living with substance use disorders. And then finally, stigma and bias. I think we're still all trying to figure out how to address this within our individual care systems and at a larger level. But that definitely affects both the chance that a patient will reach out for help and care during pregnancy, as well as their ongoing engagement of care and then retention and care after delivery. I want to switch just again, give you an overview on medications for opioid use disorder. Again, this specifics and details are outside the scope of this talk, but this is just to provide a little bit of hope that we do have something, especially for opioid use disorders, that have been found to be beneficial. So we know that medications for opioid use disorders in pregnancy, we're really talking about methadone and buprenorphine, have definitely proven benefits. We know they prevent opioid withdrawal symptoms, which can be dangerous for the baby during pregnancy, reduce the relapse risk, which decreases risk for both mom and baby, improves adherence to prenatal care and substance use disorder treatment programs, and then reduces risk of obstetric complications, all those things we talked about at the beginning of the talk. One pregnancy-specific thing to keep in mind with methadone is that because of the physiologic changes during pregnancy, there can be a decreased response to the dose in the third trimester, especially because of increased rapid metabolism. You may actually have to split their dosing into twice daily dosing. And at the bottom here just kind of shows you sometimes some methadone clinics are less comfortable with split dosing. It just increases the chance of, or it increases complexity in terms of what to do with giving doses and things like that. But if you kind of ignore inadequate dosing, it leads to these kind of chronic mild moderate withdrawal symptoms, which can increase fetal stress, increase cravings for mom, increase the risk of relapse and risk of treatment discontinuation, which can lead to the poor obstetric and neonatal outcomes. So it's definitely something we're aware of in pregnancy and need to work on to make sure that patients are getting the treatment they need. Another big misconception we address is that people, excuse me, I'm getting over COVID. People think that if they are on a less decreased dose of, say, methadone or something during pregnancy, then that automatically means there's less risk for their baby. And that has just been shown to not be true. The incidence and duration of any neonatal withdrawal symptoms does not differ depending on dose. So I really try to emphasize with my patients that they need to be on whatever dose they need to be on for their medical condition of substance use disorder. And again, if they're trying to go down for the sake of baby, they're increasing their risk of relapse, increasing the risk of poor outcomes without proven decreased risk of these withdrawal symptoms for baby. And there is some, just to go back to that split dosing we were talking about, there is some evidence that supports lower neonatal withdrawal symptoms in the setting of split dose regimens. I'd just like to end with a brief discussion of buprenorphine. It is something that we are using often in our patients. There's a lower risk of overdose because of the pharmacology and that partial agonist activity of buprenorphine. There are fewer drug interactions. We don't have to worry as much about that QTC prolongation that you have to do with methadone, and especially all the nausea meds and everything else that you might need in pregnancy. You can treat it as an outpatient. So, you know, a lot of patients have significant barriers with getting to a methadone clinic every single day, and buprenorphine allows us to at least make it so they just need to come in every week or two to get their medications. Big studies have shown that there are improved neonatal outcomes when you directly compare buprenorphine to methadone. Less morphine is needed to treat any symptoms. Babies tend to stay in the hospital shorter periods of time and need shorter duration of medical treatment. I just want to emphasize that this does not mean that methadone is not recommended in pregnancy. It just means that there are benefits to buprenorphine over methadone for that reason. Disadvantage of buprenorphine, we have a lot of data on it, but not as much as methadone. It doesn't mean that we have any data showing that it's dangerous. We just don't have the amount and long-term data that we have for methadone. There is a dropout rate due to dissatisfaction with the medicine. There's a risk of precipitated withdrawal with initiation, and this is something we run into. We initiate all of our pregnant patients who want to start on Suboxone. We admit them to the hospital and monitor them carefully, and especially if they've either been on methadone previously or were using heroin, fentanyl, whatever other type of opioid, we have to really watch them carefully, make sure that they have evidence that enough of those opioids have cleared from the receptors so that when we start the buprenorphine, that we're not precipitating worse withdrawal. And there is always a risk of diversion with any medication that they have a week's supply with them at home. So that was a whirlwind review, but hopefully it gave you an idea of both the seriousness of the issue of substance use disorders in pregnancy, as well as a few of the considerations when we're talking about methadone or buprenorphine as treatment for substance use disorders in pregnancy. Thank you so much. And at this time, I'll turn it over to Liz to talk about the Medicaid portion of this.
Thanks so much, Dr. McKinney.
We can see your slides, Liz.
Okay, thanks. Thanks for your patience. How about now?
Now it's the presenter mode. So maybe you can display settings switch. Swap. Yeah. Is that better for you?
Yeah, can you still see notes?
Yeah, now we see the slide presentation.
So no notes?
No notes.
Okay, thanks, Emily. All right, thank you so much, everyone, for your patience. I'm going to get started on the Medicaid overview portion of this presentation, talking specifically about benefits that are available through Texas Medicaid for pregnant women with substance use disorder. And I want to start off my piece of the presentation by talking really briefly about Medicaid managed care programs. So most Texas Medicaid members, including pregnant women, receive their services through a managed care organization, also called an MCO or a health plan. And these MCOs provide a medical home through a primary care provider and referrals for specialty care as needed. So the state's Medicaid programs use the acronym STAR, which stands for State of Texas Access Reform. And I'm going to go over a quick overview of these bulleted programs. So the first bullet that's just simply called STAR is the program that provides primary care, acute care, and pharmacy services for pregnant women, newborns, and children. So most pregnant Medicaid members will have coverage through the STAR program if they qualify for coverage because of their pregnancy. Some pregnant women who qualified for Medicaid through another program previously would remain in that program and receive the same services that I'm going to talk about today related to substance use disorder. So for instance, the STAR Plus program provides, it integrates the delivery of acute care and long-term services and supports for adults who have a disability or are above the age of 65. The STAR Kids program serves children and young adults up to age 20 who have disabilities. And finally, the STAR Health program provides benefits for children and youth in state conservatorship and some former foster children. So the main takeaway is that most pregnant women in Medicaid who qualify for coverage because of their pregnancy, most will be in the STAR program. Next, I'm going to go over just some of the main Medicaid benefits related to substance use disorder. You can see this list on the screen. I also wanted to mention that because of the public health emergency, many of the Medicaid substance use disorder services were able to be delivered remotely through telehealth, which expanded access and options for many Texans. Due to the recent House Bill 4, which passed in the 87th legislative session, the most recent session, HHSC is required to develop policies and procedures to make some of these changes permanently available via telehealth by September 1st, 2022. So this coming September. So for the best place to reference those changes as they're made available is to go to the HHS website, which is hhs.texas.gov, and go to Medicaid and CHIP teleservices for the most updated policy on that. First benefit that I'm going to talk about is screening, brief intervention, and referral to treatment, sometimes referred to by the acronym SBIRT. This is an approach to the delivery of early intervention and access to treatment for people with or at risk of substance use disorders. This occurs at the individual level and then has the 3 cascading steps depending on the initial screening results. The screening takes place first. Providers are required to use a standardized tool for the screening to identify those problems related to substance use. I showed a few examples here on the screen. This is not an exhaustive list. It's just a few examples from the TMPPM. So I also want to take this time to mention that the latest and full policy guidance can always be found in the Texas Medicaid Providers Procedures Manual, which is on the TMHP website, tmhp.com. That is, this presentation that I'm giving is really just a snapshot of those benefits, and the full policy language that's frequently updated can be found in the TMPPM. So related to the SBIRT benefit, the TMPPM lists the following tools: the alcohol, smoking, and substance involvement screening tool, or ASSIST, which is actually the World Health Organization's tool. the drug abuse screening test or DAST, the alcohol use disorders identification test or audit, and then the CAGE assessment, which uses the kind of coded words that tease the questions, which are cut, annoyed, guilty, and I. And so, like I said, that is not an exhaustive list. Additionally, toxicology results can be used as long as that is documented. So following a positive screen, a brief intervention can be performed. This involves a conversation about a person's screening results to raise awareness of their substance use and any consequences that have happened as a result of substance use, while also motivating the person toward behavior change. And then if a severe risk to alcohol or substance use is indicated, the provider will determine if there is a need for additional treatment and make a referral. If the person is already established with a behavioral health provider, the patient may be referred to that person. So I was also involved in a statewide provider survey on screening for pregnant women in August 2020. And so 72% of the providers that responded to the survey stated that they do conduct universal substance use screening for pregnant women in their practices, which was really great to hear. However, 62% said that they were not aware that Medicaid had an expert benefit that could be billed for that. So I'm excited to hopefully provide more knowledge on that today and dispel any understandings or just raise general awareness of some of these Medicaid benefits. So in terms of the expert requirements, there are a lot of different provider types that can deliver expert. I listed a few on the screen. However, I'm going to read off the full list here. Physicians, registered nurses, advanced practice nurses, physician assistants, psychologists, licensed clinical social workers, licensed professional counselors, certified nurse midwives, outpatient hospitals, federally qualified health centers, and rural health centers can all provide expert. Additionally, unlicensed providers can deliver expert under supervision if that is within the scope of the licensed provider's practice. So there's a lot of different provider types that can deliver this feature. All of those, whether licensed or unlicensed, must complete 4 hours of an expert related training, including like a motivational interviewing training, and that must be completed and proof maintained in their records somewhere. Additionally, Medicaid reimburses for expert at 2 different rates, depending on whether an intervention is needed. So if an intervention is needed, documentation would just need to include that a plan has been established, and that plan would detail a person's goals and any support systems that they have. expert has a limit of 2 screening only sessions per rolling year and 4 sessions of a screening and an intervention in a rolling year. The next benefit I want to discuss is the assessment. So any substance use disorder treatment requires a face-to-face multidimensional assessment conducted by a qualified credentialed counselor or QCC or intern to determine a course of treatment that is medically necessary and clinically appropriate. This assessment takes place in a chemical dependency treatment facility, CDTF, or opioid treatment program, OTP. And as I mentioned before, there may be flexibilities on this in the future, as you'll notice that the language says face-to-face currently, but this language is changing due to those telehealth flexibilities. So I would encourage you to look at that Medicaid CHIP services telehealth page to see if there are changes here in the future. The next benefit is outpatient substance use disorder counseling. This type of counseling can be done in an individual or a group setting with up to 16 people in a group setting. Individual counseling is billed in units, which are 15-minute increments for a maximum of 26 hours in a calendar year. The group counseling has a maximum of sessions rather than being billed in units like individual counseling. So that uses a different code that's not a timed code. And so there's a little bit higher maximum sessions and potentially length of those sessions, which is at the discretion of the provider. And so both of these can be exceeded with prior authorization if medically necessary. Medication-assisted treatment, sometimes called MAT, is a recognized best practice for both alcohol use disorder and opioid use disorder. In terms of Medicaid billing for medications for opioid use disorder, both methadone and non-methadone administration must include a modifier for billing or the claim will fail. I thought that was important to mention for providers that are listening. This just needs to indicate whether the dose was a take-home dose or whether it was administered in a facility. Different medications for opioid use disorder can be provided in different settings, which include opioid treatment programs or OTPs, chemical dependency treatment facilities, as well as office-based opioid treatment programs, like also called OBOTs, and a variety of other outpatient settings in terms of the dispensing of buprenorphine, specifically by qualified providers that have a federal X waiver to be able to dispense buprenorphine. And so I included a star by the word X waiver just to indicate that the federal guidance was updated in April 2021 to waive the training requirements for providers who are treating less than 30 patients with buprenorphine, but they would still need to go through the other steps to obtain that X waiver. And I want to mention one more thing on that. So qualified providers that can dispense through that X waiver are physicians, physician assistants, nurse practitioners, advanced practice registered nurses, clinical nurse specialists, nurse anesthetists, and certified nurse midwives. And so more information on the recent guidance from the federal government on the relaxed training requirements for X waivers can be found on the SAMHSA website. And this table here just shows the different medications that are approved as Medicaid pharmacy benefits for alcohol use disorder and opioid use disorder. The only benefit that is not covered as a Medicaid pharmacy benefit is methadone, which we're going to talk about next. So methadone is limited to opioid treatment programs, which are also referred to as narcotic treatment programs. And opioid treatment programs are the only settings permitted by law to both induct and maintain a patient on methadone for opioid use disorder. Opioid treatment programs comply with additional state and federal requirements that govern their licensure, scope of practice, supervision, physician delegation. And so they have a lot of requirements there that they follow. There are some special circumstances. So some hospitals are also licensed as opioid treatment programs. However, even in a circumstance where a hospital is not licensed as an OTP, hospitals can maintain methadone treatment for an inpatient person who is already established on methadone. They may have to coordinate with an OTP or their hospital pharmacy to do so. So for a pregnant woman who is admitted inpatient for some reason that's not related to her treatment for substance use disorder, if she's already established on methadone, the hospital can continue that medication for her, whether or not they are licensed as an OTP. And there's also a 3-day emergency dosing rule through a hospital emergency room in the event that a clinic closes or there was some type of natural disaster. Methadone is reimbursed at a fixed daily rate, and it can only be reimbursed once per date of service, since women would be seeking methadone typically on a daily basis. The record keeping for billing just needs to reflect that and can't be billed more than one per day, or that claim would fail. Withdrawal management, previously called detox, is available as a Medicaid benefit and is covered in multiple settings. So at the inpatient hospital level, that setting is available for people who meet hospital level of care requirements due to the expected severity of their withdrawal or comorbid psychiatric or medical conditions. Additionally, Medicaid covers withdrawal management in a residential setting, which is provided in a chemical dependency treatment facility and is allowed for up to 21 days per episode of care. And finally, withdrawal management is covered by Medicaid in an outpatient setting, but an individual needs to match the criteria. And so the criteria includes whether they're expected to have a stable withdrawal, whether they have a history of seizures, whether they have stable vital signs. Is the person living in an environment where illicit substances are not being used? So this is, once again, not an exhaustive list, but the full list is available in the TMPPM. Residential treatment services are available for people who have a more severe substance use disorder, significant medical or psychiatric comorbidities, and or challenges with sustaining motivation in an outpatient setting. So residential substance use disorder treatment services can only be delivered by a licensed chemical dependency treatment facility, and each episode of residential treatment is limited to 35 days. Individuals can receive up to 2 episodes per rolling 6-month period and up to 4 episodes per rolling 12-month period. And once again, providers can submit authorization requests for individuals who require additional episodes within the 6 or 12-month time frame. I also wanted to include that there are aspects of residential treatment that are not covered by Medicaid. So some wraparound services like additional educational classes, life skills, and vocational training, as well as childcare costs if a child is in residential treatment with a parent. So what in an instance like this where Medicaid doesn't cover that service, it would generally be picked up by state block grant funds who are payers of last resort. Next, I want to talk about peer specialist services. Peer specialist services are available through Medicaid for mental health conditions or substance use disorders as a benefit for people who are 21 years of age and older, and who have their peer specialist services included as a component of their recovery plan. So these services can be delivered individually or in a group setting with up to 12 people per group. And services are classified across 3 categories, which are recovery and wellness support, mentoring, and advocacy. Any peer services must be submitted with a modifier to indicate whether they are mental health or substance use disorder specific, and whether they're delivered in an individual or group setting. Peer services are also billed in units in 15-minute increments for about 26 hours in a 6-month rolling period, and that can be exceeded with prior authorization. One limitation to peer specialist services in Texas Medicaid is that they cannot be provided in an inpatient hospital setting or an incarceration setting. And peer specialist services cannot cover the time spent doing record keeping or administrative tasks. I wanted to include a slide here on peer providers because we're going to be talking about the MOM model here in a bit, and peer providers are such an essential part of the MOM model. So I wanted to include a slide, and perhaps there are even some peers listening today, and they're such an important part of this work. So I wanted to include a slide on how to become a certified peer specialist. So the Medicaid billable peer specialist has only been, these services have only existed in Medicaid since around 2018. So they're new-ish. And so the process to certify as a Medicaid billable peer specialist, which the credential title is Recovery Support Peer Specialist, is also somewhat new. A person would undergo an orientation, a series of self-assessment activities, an application, and a core training delivered by a certified training entity. They would also complete a supplemental training in one of 2 specialty areas, and then receive their initial certification when their supervised work experience is complete, after which they can bill to Medicaid, and then they will eventually receive their 2-year certification. Additionally, peer providers in Medicaid do not bill directly. They bill under Medicaid billable provider types, such as a behavioral health clinic, a physician, psychologist, chemical dependency treatment facility, local mental health authority, federally qualified health center, or opioid treatment program. There's also an opportunity with the latest training framework in the state for existing peer trainers to grandfather and be able to bill to Medicaid. So I would encourage people interested in that to look at the HHS website on peer support. Has some good information on that. I also wanted to share on some other benefits available for people with substance use. Service management and coordination is an administrative function that's provided by managed care organizations for members with special healthcare needs in the STAR program. So pregnant women in the STAR program with a substance use disorder would qualify as a member with special healthcare needs and be eligible for this service management service. So service management involves creation of a person-centered service plan, as well as coordination of services among a member's primary care physician, any specialty providers they see, and non-medical providers as well, just to ensure that they have access to all of the services that they need. Tobacco cessation services in the form of individual or group counseling were initially a benefit developed in Medicaid for pregnant women, and it's now been expanded to include all male and female members 10 years and older. So these services can be delivered in a group setting with no more than 8 services in a year. However, this can be extended with prior authorization that documents medical necessity. Medicaid also has a transportation program. Managed care members can receive non-emergency transportation services to appointments or places where they receive Medicaid covered services through different means, including public transportation vouchers, ride sharing services, or even reimbursements to a family member who registers for that program. So the best way to learn about this process for members is to call the MCO's medical transportation number to arrange transportation or to learn more about that service. And then we also have the managed care organizations. They offer additional services that they are not required to provide, that are not part of the Medicaid state plan, that target health and wellness. So these are called the value added services. So when a pregnant woman is asked to select an MCO in her area, she may receive a list of value-added services that the MCOs are providing. So examples for pregnant women of commonly advertised value-added services may be something like childbirth education classes, car seats, diapers, gift cards for completing prenatal checkups within a certain time frame, and things of that nature. This next slide is on understanding Healthy Texas Women Plus after Medicaid. So the state's Healthy Texas Women program offers women's health and family planning services at no cost to low-income women without health insurance in Texas. And so HTW Plus is a postpartum services package for women who are up to 12 months postpartum. The benefits of this program focus on treating health conditions that contribute to maternal morbidity and mortality, which include postpartum depression, cardiovascular conditions, and substance use disorders. So as you'll see from this list, many of the Healthy Texas Women Plus benefits cover a lot of the same substance use disorder specific benefits as Medicaid, with the exception of residential treatment and withdrawal management. Due to the public health emergency, women's pregnancy-related Medicaid coverage is continuing at the moment. However, prior to the public health emergency, pregnancy-related Medicaid coverage lasted until the last day of the month in which the 60th day postpartum landed. I also wanted to mention House Bill 133 from the latest legislative session. This House bill requires HHSC to send a request to CMS to extend the postpartum coverage to 6 months effective September 22nd of this year, if approved. So there are updates that are pending on this subject, but I think the main takeaway here is that after pregnancy-related Medicaid coverage ends, HTW Plus is available to women in the postpartum period and offers many of the same substance use disorder benefits as full Medicaid coverage. And currently this program is delivered on a fee-for-service basis and is not in managed care. Okay, I'm excited to introduce the mom model and then turn it over to Emily Ybarra. So I want to first just identify the disclaimer at the bottom. So the mom model is 100% funded by the Centers for Medicare and Medicaid Services, or CMS. And all of the speakers today have some portion of their time allocated by mom funds. And our views, of course, do not represent the views of the federal government. So just some history of the Texas mom model and how it came to be. You heard from Dr. McKinney earlier about some of the stark Texas maternal mortality data, especially data indicating overdose as a leading cause of death in the 12 months postpartum. So this data, as well as Senate Bill 750, which passed in the 86th legislative session in 2019, prompted HHSC to apply for this opportunity for funding. So HHSC applied for the federal funding available, which was to implement a model of care that addresses pregnant women with opioid use disorder who are enrolled in Medicaid during the prenatal and postpartum periods. And so as a result of this, HHSC applied and received the mom model funding in December 2019 and learned that it was one of 10 states total selected to be part of the model. The program structure of the model: Texas HHSC as the state Medicaid agency is the main awardee of the funds. HHSC chose to partner with the Harris Health System in Houston, a healthcare safety net hospital system, as the main care delivery partner for the model. And Harris Health partners with Baylor College of Medicine, Santa Maria Hospital, and Patient Care Intervention Center. And Emily's going to talk more about this, and she has a nice visual on a slide later. This is a page with live links and lots of resources that I mentioned. And I wanted to leave my email if anyone has specific questions. And I'm going to turn it over now to Emily Ybarra. Thank you so much.
Hey guys, can you hear me, Liz? No,
I can hear you. Sorry, I'm just starting to.
no problem.
Okay,
And
got it.
then can you see my slide presentation?
Yes.
Great. Hi guys, thank you for having me. My name is Emily Ybarra, and I'm the nursing program manager at Bentop Hospital for our maternal substance use program. I'm sorry, you guys cannot see the video, correct? Just slides, right?
I just see slides.
Excellent, thank you. So as Liz said, back up. I'm going to talk to you about the maternal opioid misuse, the MOM model, but I'm also going to talk about where the work takes place for this model, and that is in our clinic at Bentop. We call it the MPAT clinic, our maternal perinatal addiction treatment clinic. As was said, this work is sponsored by the Centers for Medicaid and Medicare Services, so their Innovation Center. And it really is, well, obviously, as Dr. McKinney shared, to address the role of maternal mortality in the state of Texas and specifically around the country. Texas is one of 8 sites in the country doing this work that has been awarded the MOM model funds. And we really are, the goal is really to improve quality of care and reduce costs while making sure women have well-coordinated care throughout their pregnancy. This is the model and all of the partners within it. You can see Texas HHSC at the top. We at Harris Health System are the care delivery partner, and the providers that we work with are Baylor College of Medicine. Santa Maria Hospital is a crucial member of our team as well. And in the bigger circle, you see the Patient Care Intervention Center, PCIC, which helps us with our data and reporting to CMS on our outcomes for the model. Right in the middle of all of the circles is our mom model clinic, also called the MPAT clinic at Bentop Hospital. These are the key staff involved in the work that we do. We have a social worker, her name is Gardenia Garza Paul. We have lactation health educators. We have all of the specialists on the team from Baylor College of Medicine, including Dr. McKinney, who you heard from earlier, and Dr. Carrie Epps. Dr. Gannon is our neonatologist, and Dr. Andres Ojeda Avellaneda is our addiction medicine psychiatrist. Dr. Zombre is our OB anesthesiologist. And I just share their names because, again, this work is, every person on the team is just so important, and I just want to give them all credit. Santa Maria Hospital has our amazing peer coaches on our team too, Michelle Hansford and Katie Jacobs. So I also wanted to make sure I'm really clear on the scope of our services at Bentop. I'm going to focus mainly on the mom model in my talk today, but our MPAT clinic sees women with all substance use disorders, including those that may not even have opioid use disorder, but might have other stimulant use disorders. So the overall work is extremely important. And as Dr. McKinney was saying, women with opioid use disorder who are pregnant are a portion of our overall MPAT clinic of pregnant women with substance use disorder. So I wanted to share that on the front end for any clarification. So what do we do at our clinic? We screen all women for social determinants of health. We know this should be the standard of care. We know women that we see, their main issues are not always health related, or not always medical related, I should say, but the housing is a big issue for a lot of our women. Our women are justice involved. Some women have intimate partner violence situations that they're in. And so we want to make sure that we're screening for all of these issues. And so we're, again, doing comprehensive coordination of care. Every specialist that you saw on that last slide is in our clinic. Even our peer coaches come to our clinic, and we are co-located, so we come to the patient, make it as easy as possible for them to get care. At Bentop, we are an entry point into care, and then we want to facilitate ongoing prenatal care. So for example, we identify a woman in the community, and oftentimes it's through Santa Maria, and they are interested in treatment for the opioid use disorder. We will see them in our hospital so we can safely start them on a medicine for opioid use disorder. We will admit them to our antepartum unit where they can start their treatment. And then the goal is to coordinate with them prenatally in the postpartum care setting. So that is a big part of the mom model and our substance use program, is to make sure we are an access point for women. As I said, Santa Maria Hospital is our key partnership. They work to identify women in the community. And then if a woman has been identified by us, she shows up for a medical concern, we will work with Santa Maria to get that pregnant patient involved in their care, whether it be residential or outpatient. We also collaborate very closely with the opioid treatment programs because that's essential, especially if mom obviously chooses methadone as her medicine for opioid use disorder. So I'll talk more about that in our upcoming slides as well. But first I want to share this graphic of like everyone involved in the care. So as I said, Dr. Ojeda is our addiction medicine psychiatrist. He will start women on buprenorphine treatment if that is their choice. And he will do, so that will be started inpatient, but then on the outpatient side, he will see them to continue on with their buprenorphine treatment if that's what they are, if that is their decision. Obviously, our OB providers are in care, are in our clinic. Dr. McKinney is one of our MFMs, as well as Dr. Epps. Dr. Zombre, her role is really around seeing women prenatally so we can come up with a good pain plan for labor, including mode of delivery. So we know that there's a big fear and concern among many women with opioid use disorder about their pain management. And so she sees our patients, again, prenatally, so we can allay those concerns, have a plan and a backup plan, and make sure that that's been evaluated on the front end of their care. Our neonatologist, Dr. Kathy Gannon, also sees our patients prenatally in clinic, so women know what to expect and how their baby is going to be cared for at delivery. So it's a really great conversation about management. Women or babies that have been exposed to substances and treatment. So let me clarify. Babies that are exposed to medicines for opioid use disorder, the treatment for the OUD in moms, all of our babies are monitored for at least 4 to 5 days, even if they're not showing any symptoms of withdrawal. So Dr. Gannon talks with our patients about that. And then we also have a room called the Care by Parent Suite, where if mom is discharged before baby, so mom's delivery goes smoothly, and she can be discharged, mom can then go with baby to our Care by Parent Suite to room in with baby while baby's still being monitored in our level 2 nursery. The program that we use is called Eat, Sleep, Consult, and that allows us to continue that program with mom as the main medicine for her baby. Every situation is different, but that's a brief overview, and we get lots of questions about Eat, Sleep, Console, and that's a whole nother topic because it's a fabulous program, but I just wanted to quickly touch on that. We work closely with Texas state agencies like DSPS, and specifically we work with the Plan of Safe Care. The Plan of Safe Care, I'm sure many of you on the call have heard about it. It's a fabulous tool. It's actually a binder, and it's really like a recovery resume for mom throughout her prenatal care to show her engagement in care, to show her treatment plans, to show how many negative drug screens she's had, her progress in care. And it's really a way for mom at delivery to demonstrate to CPS if that is ever, if they are involved. So I know many moms come into our care extremely concerned about CPS involvement. Maybe they haven't had involvement in the past because their substance use disorder has not been treated. So this is a really great way that we can work with Child Protective Services to demonstrate, again, mom's engagement in recovery. Our social worker, I did talk to you guys about that. She also helps women to access and be informed of the benefits that Liz Conville was stating, things like transportation. Many women don't even know that that's available for them and haven't been utilizing those services. So she helps with that. Of course, PCIC is crucial for our data and reporting, and they also have a really cool repository for local community resources that we can access with their tools, their platform. So sometimes our social worker also uses their platform to access Houston area resources, for example, like food banks or childcare options that might be available. So we could not do this work without Santa Maria Hospital. I can personally tell you, I talk with them, a member of their team, most every single day, because the collaboration is really essential for our patients and their recovery journey. So they're with us every step of the way. As I said, they identify women in the community to get them into care. And then they might have women come on the inpatient setting to initiate their medicines for opioid use disorder if that is their substance use, or if that is their drug of choice that they're having issues with. And then if we identify women on the inpatient side or the outpatient side at one of our prenatal clinics, we will connect them with the recovery coaches at Santa Maria so we can identify what treatment and recovery approaches are best for mom. So as I said, the peer recovery coaches are in our clinic every week. So they are part of our huddle with the whole treatment team, including everyone in that circle that I showed you. So they're there with us. They work hand in hand with us. The goal of our patients that are engaged in our MPAC clinic is really continuity of care even beyond delivery. So that is definitely a positive outcome when mom can continue her medicine for opioid use disorder after delivery to the postpartum period. Because of that, we will see women throughout their first year postpartum. We will continue seeing them, and if they're on buprenorphine, for example, we will continue being their addiction medicine provider for that first year after postpartum, before we would then link them into another provider. I also mentioned the pain management plan, the care by parent suite, and the plans of safe care. So how did we start this work? We started this work it was a big, heavy lift. So a year ago, we went live with the MOM model and started our engagement and identification of women with substance use disorder as part of the MOM model. So in June of last year, we did a training for all of Harris Health System prenatal providers and nursing staff to make sure that we were screening for substances using one of the screening tools that Liz mentioned. At Harris Health System, we use the DAST, and we wanted to make sure that all women getting prenatal care in one of our clinics was getting screened for that. So we had to build a workflow in our electronic health record in Epic. So that we had obviously many partners involved with that, including our IT and our ambulatory care Epic specialists. So we built the workflow. We trained all of our prenatal providers, including midwives, nurse practitioners, and OB providers in one of our 9 prenatal care clinics in our Harris Health System on escort and motivational interviewing. So we know that verbal screening works best than any urine drug screen for getting women engaged into substance use treatment. So that was the approach that we took. So we screen all women at their first OB visit, no matter what gestational age, for substance use disorder. If a woman is identified as high risk of having a substance use disorder, we will, the provider in the community is then able to do a referral. The note is built out for them in the electronic health record, and then it comes straight to us. But I will tell you, the majority of time, we don't get, the majority of the time, the providers will just call us directly, which is great because it's a nice warm handoff. We also have ongoing outreach, obviously, to our community stakeholders. We, on the flyer that you'll see at the end of my presentation, and then that you saw on the title slide of this presentation, it is a flyer that has information about our program, as well as a way to get direct contact with us. And there's also a QR code where a woman can self-refer if she prefers that way, in a secure portal to get services for opioid use disorder or other substances. We've also shared our program, about our program, with the Southeast Texas Regional Advisory Committee, the maternal and neonatal programs. That is our regional committee that involves all of the perinatal providers in our region. We have really this year improved our partnership greatly with the methadone clinics. And now we have women that will directly call us up to make their appointment when they find out that they're pregnant. We know that women with substance use disorder also have co-occurring mental illness. And so if we see that a woman has been admitted to HCPC, the psychiatric center in our area, we can also work with those providers, as well as the Texas Heroes program, which is a really great program in the Houston area that works with EMS providers to identify people with opioid use disorder and to engage them in treatment. And sometimes they have women that have also found to be pregnant, so they can come get care at our clinic. And this year, we're really focused on growing our Harris County Correctional Health relationship. Harris Health System just this year officially acquired the correctional health program at the Harris County Jail. So it's really been a really great opportunity for us to facilitate prenatal care for women who are incarcerated and also have opioid use disorder specifically. Challenges. There are many. So obviously, HHSC got the contract for the mom model before the pandemic. And so we started this work before the pandemic, but launch and go live happened literally in the middle of the pandemic. So that was very challenging and a very real barrier. So staffing was an issue. I myself had to work the floor because we were so short on nurses. Access was an issue. We were short on nurses. Staff was getting sick, especially during the Delta wave. So at one point we had to close our antepartum unit, which is where we admit patients who have who are starting on their medicines for opioid use disorder. We also had outreach limitations because of COVID and social distancing. I mean, most of us on the team will agree that these issues did create slow initial enrollment, officially in MOM, but the whole time during the pandemic, we were seeing patients in our MPAT clinic with all substances. It just initially was a slow start. Very real challenge is contracting in IRB. We often don't think as clinical providers how important the role of those team members within our health systems are. I mean, we had significant delays with that, again, because of staffing. It hit all arms of our organizations. So that was something we had to get through, and we did, which is great. And then also initial data collection scoping. As you go through any program, you learn what data points are very crucial to recording. And so when we scoped the project initially, we built a lot of data elements and infrastructure on the front end, but we had to reassess and add more so we have a more robust and comprehensive picture of the work that we're doing. So that was a heavy lift as well. Specifically related to patients, on the front end, some lessons that we've learned to help improve our engagement with patients ongoing prenatally and postpartum is really setting the expectations and identifying what MAT treatment works best for them. So if going to a methadone clinic every day is a barrier for the patient for many reasons, it could be geographical. We have patients all over Houston. Everyone here knows how huge Houston is, and we don't have enough OTPs around that accept Medicaid. So if that's a barrier, let's be very aware of that and talk about perhaps buprenorphine as a better option for them, because that's again, the goal is always engagement and continuity of treatment. So if that's the barrier, we want to address it on the front end so we can all work towards keeping women engaged. Plans of safe care, hugely beneficial tool. And we do use that tool throughout the pregnancy and really just talk it up, because it's not just a way for mom to be engaged in care. It's also a way for her to set goals for her future. What does she want her life to look like after this baby is born? What are her goals, as a person, as a human, and just like getting focused on mom specifically. Collaboration with the methadone clinics. We did not have that great collaboration in the very beginning, but that has improved and it's been really great. And so I talk with a representative from the methadone clinics weekly because we are really trying to coordinate care. Gel collaboration, I did mention that has been a really important opportunity, and that is really going to be a primary focus this year. So as we do this work, we know there's a big learning curve for staff that see women with all substance use disorders. Our team is very compassionate and aware of the stigma and bias that our women encounter when they try to access care. So we really do our best to constantly re-educate and be accessible and available to providers on the floor who are encountering women. It's important because we want the experience to be as positive as possible for our patients, and we don't want to be another barrier for them to get engaged in care. One example I have of this too, just in general about the women that enter our program, I mean, we get patients all the time that said that their OBs would, when they found out they were on methadone, they would say, oh, I don't work with women who are on methadone, and you should probably stop taking that since you're pregnant. Same with other women who were on Suboxone, who were told by their OB providers that they should stop their treatment and that they don't work with women who are on Suboxone. So they've had stigmatizing experiences when they're trying to do the right thing in access care. And so it's an opportunity for us to educate the community and other providers about safe care for women with substance use disorder. Another big part of things that we've learned is balancing time demands while reducing barriers to care. So this work takes a lot of time, and these patients are complex. So it is complex work, but we recognize that having as low barrier access to care as possible always has been, and well, that should be the standard for anyone, but it really helps this population, because if they're waiting through 5 different call trees to get to talk to a nurse, or if they miss an appointment, or they're running late, having a direct phone line to talk to someone clinical has been huge and has really helped maintain the engagement. So accessible communication is something that we really have learned has helped the patient engagement. Success stories. We had a patient just, one of the patients last year that we initially enrolled, and she started her OUD treatment, and she said, I never knew I could feel better. She started buprenorphine. She didn't even know that was an option. She had been using oxycodone pills, and she started her treatment, and she was in tears, happy tears, because she never knew she could feel better. She just thought that was kind of going to be her world. And so just getting the word out there for women that there are places where they can get help and there's treatment that works has been a huge success for us. Enhanced relationships and recovery capital building with SCD patients. I mean, they know that there's a treatment team that cares about them. There's recovery coaches there that are supporting them all along the way. It's been a really great, it's just a great thing to see when we have these women engaged, they have their babies, they're so happy, and it's just another new chapter of their life that they're really excited about. Increased collaboration with community organizations and healthcare services. I mean, this is the way it should work anyways, right? But we just kind of are we have hardwired that into our model. So that's been really fabulous. And another success has been that of the moms that we've delivered in our program since last year, because we launched July 2021, that was our official implementation year start. The majority have maintain primary care of their babies that have delivered, 73%. I do want to say that maybe that shouldn't always be, some moms, for example, should not always have their baby in their primary care. And that can be because maybe mom's not ready in her treatment progression to have care of her baby. And so that's maintaining primary care of a baby may not always be the bar for success, but it's been something that we've been able to see and witness, and that's been a big win for our patients. So this work is so important, and we always need to talk about sustainability and growth, and that's been really the purpose of the MOM model. We received funds to set up this work and set up the foundation, but the sustainability is supposed to be maintained within Medicaid and accessing benefits that are already there. So that's really what we're working towards, and we're creating the infrastructure to do this work. So we're continuing targeted outreach. We wanted people to know that we're there, continue to grow relationships within our community. And we've just within the past month, we've been talking to our leaders at Harris Health System about growing clinic capacity, because there continue to be more and more moms to serve as the word is out that there are services for women with substance use disorder. And then also, we always want to use data to inform conversations with our state agencies, our health plans, our policymakers, because this work is extremely important, and we want to demonstrate the positive impact on maternal morbidity and mortality that we're having, and be able to have a seat at the table to show the importance of this. We want to be creative with policies that we've not maybe done before. So if alternative payment models exist that we haven't thought of to do this work, let's go for it. Use data to adjust for optimization of services. I mean, if we can make, for example, OTPs more accessible for women who are pregnant and not having to show up every day at a clinic, you know, let's be creative. We want to try to think outside the box and use our data to make that case. This is my last slide. This is our lovely slide that we're all very, our lovely flyer that we're all very proud of. We will share this link with you guys. It is on the HHSC website. If you Google Texas Mom Model, you'll see it. So there's a link to our PDF. And there's our information and the QR code for moms that can privately self-refer if they are interested. Here's my contact information. Again, our goal is to be as accessible as possible. And we just really thank you all for your interest in this work. And we're happy to take any questions if anyone has any. Thank you.
Can y'all hear me?
Yes.
Okay, yeah, if anybody has any questions or comments or anything they'd like to share, you can type it in the comments. Or if you want to type it in, type it in the chat, or if you'd like to unmute, we'd be more than happy to hear from you.
Hi, my name is Kimberly Sinat. I'm a midwife and a mental health nurse practitioner in the Austin area. And I just love what you all are doing. And I was wondering, do you have any relationship to your neighboring cities? And if so, like, you know, if one was interested in kind of like reproducing a similar program, how would you all, like, what are some of the steps or contact people?
Yeah, we definitely want to share this work. Please reach out to me. And that's actually our goal. And one of the pieces of the work is to share and educate others so they can stand up services like this in their community. So yes, please reach out, Kimberly. Thank you so much. We would love to. And I will put my email address in the chat again.
And there are efforts at the state level through Texas AIM, the Alliance for Innovation in Maternal Health. We are very, very early on in terms of bundle and efforts on that standpoint, but it's kind of both Dr. Epps and myself are part of that team, and hopefully coming up with a plan to disseminate similar model with similar features throughout Texas.
And I can echo that too. In terms of the mom model, as the model continues to generate data, we're only 1 year out of the 5-year project. Well, we're in year 3, but we're 1 year out from implementation of the project. From the state perspective, we're eager to share and try to create more models that are similar and help provide that information as well.
One other thing I wanted to add about that is Santa Maria will often get women from all over Texas because there's not many programs that will allow pregnant patients to continue their treatment after delivery and take baby with them to treatment. So Santa Maria offers that. So we often do get referrals from other parts of the state. I know we heard about Casa Mia, but we have it too in Houston.
We do have a question in the chat. It says, I'm sorry, when you say pregnancy-related death, do you refer to the death of the pregnant person or the child or both?
Yes, that's related. That's maternal mortality, so death of the birthing parent.
All right, any more questions or comments?
if any other questions come up, please feel free to reach out. We're happy to take any questions that may come up. And if I know this is Juneteenth, so thank you all for joining us on Juneteenth. Well, this is Juneteenth recognized. So thank you guys.
Well, we want to thank you guys for sharing all of that you're doing to help these moms and babies and getting through the COVID struggle. We've heard that on a couple other presentations too. Y'all are so resilient, and so are the moms and the babies. And just thank you for all you do. And we are recording this. So if anybody had to leave, or if you have other colleagues that would like to see this, we'll be posting it online soon. And you all have a wonderful day. Thank you so much.
Thanks, everybody. Bye.
Thank you. Take care.
Bye.